Good afternoon, and thank you all for joining us this afternoon. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, would like to welcome you all to the last webinar in our three-part series about providing dental care to patients with IDD by Dr. Mark Bullock. Today's webinar is in two parts. Part one is understanding and working with caregivers and group homes. And the second part is dental desensitization, advanced behavior techniques for patients with IDD at Abilene State Supported Living Center. If you missed Dr. Bullock's first two presentations, you can access both recordings on our TechSoc website. So our presenter today is Dr. Mark Bullock, a special needs dentist and dental director at the Abilene State Supported Living Center, a state facility for individuals with intellectual and developmental disabilities. He previously served as the Chief Dental Officer for Mercy Ships, providing free dental care to the people of West Africa. After earning his dental degree from the University of Texas Dental School in San Antonio, he completed a one-year Army residency in advanced general dentistry. Driven by a passion for underserved dental patients, he takes pride in providing comprehensive and compassionate dental care to patients with complex needs and challenges. As a special needs dentist, his goals include improving access to quality dental care for patients with IDD. So it is with extreme pleasure we welcome back Dr. Mark Bullock.
Welcome back to my next presentation, and I will jump right in. Yes, group homes and our desensitization program. I'm going to start with my disclaimers, as I always do. So I have no financial interest or conflicts of interest with any of this. I don't go over a lot of products. I shouldn't really have any products in this talk. That's not really this one. But the big one is I just want everybody to know I'm not speaking for the state of Texas, HHSC, or even my facility. All these opinions, everything I'm telling you is really just the way Dr. Bullock sees the world. I'm definitely not making any policy for the state of Texas, so please don't go with that. Ms. Beth gave me a very fine introduction. She always does. I do focus my practice on special needs because I work for the state at this facility, but other than my one-year AGD, I don't have any special training or degrees. Frustratingly for me, I feel like there's a lot of gap in special needs. Pediatric people have a lot of experience with it. I wish I had more, and I'll just leave it at that. So if you find some what I say lacking, yes, I always want to train more and wish I knew more. So, but I'll move on from that. So our objectives here for this one. This PowerPoint actually changed a lot as far as the group homes from when I first conceived it in my mind. I started doing my research for this and learned a lot. I know it seems like I would know a lot of this because I work for HHSC, but I work in a very small niche part of HHSC that deals specifically with state living centers. Didn't really have a lot of experience, kind of other than what I've heard about group homes and the system outside our fence. So I kind of had to amend. Really, the purpose of the first part of this talk is really just to give you as dentists some general knowledge of what I found about this system. I really am hoping this general knowledge is, if you do start wanting to work and provide dental services to people with special needs, maybe you've heard some lingo and some words that will make you just a more knowledgeable and less frustrated, because it is a frustrating system. And so I also would like a PowerPoint that you could come back to and maybe pick up some jargon from. So I'm not expecting you to memorize all this. I'm going to have a whole list of kind of acronyms. And I hope this is helpful to you, because this is what I found in my research. Is I actually spoke to some people that are knowledgeable about this, and they use a lot of words in their daily business that I don't think we understand as dentists. And we use a lot of dental stuff that they don't really understand, and that could be one of the barriers to care. It is not the main barrier to care, but it could be a barrier to care for people with IDD. So I'm just hoping to kind of overcome the barrier. The second part of the talk is really just a description of a program we have here at our facility I may get excited and be like, oh, you could do this or that. That really is not my purpose. I'm really just describing it. We spent years developing it, and I hope you find it interesting. So next, I want to open up with the first part of the talk is about the system in the state of Texas for people with IDD. I did most of my research from this paper, which was on the HHSC website, but it was very informative in a lot of ways. It had a very good historical background. I'm going to go into some of that. And the Foundation for IDD Strategic Plan, you actually have, it's a part of a bigger plan at this website that included behavioral health services. And that's often the case in the state of Texas, that behavioral health and IDD care kind of get lumped together. And I throw that out because you do need to be careful. You're going to be taught, if you talk to people in the system, you need to designate who you want to work with, okay? IDD is individuals with developmental disabilities. They have cognitive disabilities for sure, physical disabilities, and those kind of things. Behavioral health, and there's a lot of crossover. You may have what we call neurotypical people, but they have mental health problems, PTSD, anxiety, mental health problems. They may be fairly normal, but they need services more along that line. So I won't get into that because that's not what I do as much. But just be warned, you know, you end up in a very different realm when you start getting over in that side of the house. So, but our part, sort of a funny part, was the behavioral health side of things actually got a strategic plan. Unfortunately for IDD, we only got the foundation for one. I'm not sure the reason why behind that. I don't want to read too much into it. I just kind of found it interesting. But moving on, I want to provide a little historical perspective because I think it really helps understand the way the system is now, or at least it did for me. Okay, so I apologize. Hopefully don't get too boring here, but our current system, I put a big question mark here. It is extremely convoluted. I had a hard time doing research because a lot of it, you know, I'm talking to my local people, but they're telling me that things may be different in other regions. It's largely disjointed. There's several overlapping programs. It gets very confusing if you're talking about children versus adults. That there's lots of different organizations and services that that kind of make this difficult. Here's the reason why I think it's so convoluted is because I believe it's still in its nascent period, its early period. And I know that may sound crazy, but part of that paper threw out a very interesting statistic, which was in 1930, the life expectancy for people with IDD was only 19 years of age. So you didn't really have adult IDD care. They weren't around largely. It wasn't a thing. So why we in dentistry are still learning it? Because at least in the state of Texas, there really wasn't a need for it. Fast forward to 1993, now they're living 66 years is not quite normal life expectancy, but more and more of them are living into older age. So it was my only point with this slide. So I think we're learning a lot still, even here in the grand old 2020 plus years, about IDD care, and the system as a whole is also learning a lot. The other big part of the history of this type of care is that it has been changing over the last 50, 60 years from institutional to community-based care. That's very important in the state of Texas because prior to a certain time, if you had IDD problems, and they didn't call it that at the time, you lived in a facility like where I work. There wasn't any other type of care really available. And then they started trying to transition out even as early as the 50s and 60s, but it was a long time coming. Even up into the 2000s, there was actually still a pretty heavy government hand. And now it has transitioned. Unless you live at a facility like where I work, you're largely in the private sector. Now you're working with public funds, but you're going to be working with private businesses and things. So I hope that the gravity is there of why that's so different is because we call it the community didn't know necessarily what to do because it had always been provided by the government. The government doesn't always know how to tell people in the private sector how to do things because they can't do it like we do it. And so we're still in this process, I think, of transition from institutional to private care. Moving on, back to the history, some things I found very interesting. Some statistics. I'm actually not a statistician, so I apologize. 500,000. That was in this strategic plan or foundation for strategic plan as the estimated number of people with IDD. And even in that one, it said it's very conservative. They believe it's very conservative. I think it's totally wrong. I think the number is much higher than this. The problem becomes with the definition of IDD. There's lots of overlap depending on children and adults again. The way you define IDD is going to affect that number. But I kind of call IDD intellectual and developmental disability because you have that developmental in there. You know, somebody who's blind from birth, that's a developmental disability. And if you put that in with a little bit of cognitive deficiency, you can really affect your dental care. So I think if you take my definition as a pretty expansive one, we're talking about a lot of people here, but even if 500,000, that's a big number. But I think the number is much larger. So 31% was children in foster care. So 31% of children in foster care, according to that document, have a disability. Now, again, what was their use of the definition of disability? And the reason I brought this up, or I found this statistic very interesting, is because the fact that somebody's in foster care automatically makes them a special population, in my opinion. Their caregiver situation has changed from their typical parent. Also, the reason is there's a lot of kids in foster care. I didn't get this number in, but I think there's quite a few. And if 31% of them have a disability, they get out of the foster system. Where are they now? And I think those are some of the questions we're starting to have to answer as the state of Texas in this system. And I promise I'm going to get to the system here eventually. 7% was only 7% of families receive support from a state IDD agency. Why is that important? Because their resources are going to be determined by their caregiver. So I'm talking about people that are in the system today. I'm not going to so much go into, but I just want to throw that out because there are a lot of people being taken care of by their family members. If you are able to work with them, bless your heart, it's good. It's just not where I'm focused with today. I am going to kind of briefly hit on them as a place where they're found, but I just want you to know that a lot of people are not getting services from the state of Texas in Texas, and I won't get too much further into that. $2,000. Why is that a big one? That is currently kind of the buzz around, you know, if they have state-funded dental benefits, and I said I'd throw this number out to the people who help me do their research, is they wanted me to tell you this because it's so commonly the barrier is you get one of these people in your office and you spend time getting to learn them and their needs, and you provide them with this very good dental treatment plan, and you can't do it because they don't have the money. It's just the sad truth the way it is right now. I'd love to see that change. I don't think $2,000 is sufficient. It's not sufficient for the patients or the residents of my facility. So I just wanted to put that out there, that currently most people that receive dental benefits have very modest means. So take that in consideration. I would tell you to don't overload your practice unless you think you really want to, but even if you pick up a few cases, you can really help some people. There's a lot of need for this, but that's kind of the scope. So if you hear that number thrown out, yes, as far as according to my research, that $2,000 cap is pretty a hard cap. So living situations. So from my research, where I tried to cover them all, where do most people with IDD live in the state of Texas? Like I just said, 7%, was that 93% live at home with a family member, or I call them family. Let's use a broad family member. You know, it may be a second cousin twice removed. It may be somebody who calls themselves Tia or Tio or aunt or uncle or grandmother or grandfather, but they may not be blood relation, but there's some sort of familiar relationship. So watch for those people. Just know, I think a majority of people actually live in that situation. And maybe not live directly with, but are being taken care of by, if they're high enough function, they may live out on their own, but they may be getting a lot of help from their family. ICF, IDD, and SSLCs, that's us, that's here. So ICF, there's a few facilities that are not state facilities, but they're still called ICF. That's interim care facility, or IDD. That's a federal designator. It means certain things. SSLCs are ICF, IDD, but we're kind of our own special thing because we're run by the state government. So there are out there, they're going to be a little bit larger facilities, although modest. We are not huge, but bigger than the next group, which is called group homes. This is sort of a catch-all system. So currently, so way back when they started moving people out of the state system, they came up with this way for private businesses to house them. And literally what they did was private businesses buy a house, 3 or 4 bedroom house in the neighborhood. They get all the right stuff in place and they're able to house people with IDD care there. So it's kind of like a little baby nursing home, except there's sometimes as a nurse, I don't want to say, I apologize for that, but kind of similar to that system with nursing care, but it'll only be 3 or 4 people living in a home sometimes, usually. So group home is very small. A group home is going to be run, and I'm going to get more into that, but just know that that's kind of the way the system seems to want to be moving, is normal neighborhoods, normal looking home has a group of people living in it with IDD, and people come in to help support them. And then other. I don't want to call my research into this exhaustive, but I'm willing to bet that I didn't find all the situations. I also threw this other in there because I think as a population, along with the behavioral health type mental illness side, there are some of these people living in prison, they're living under bridges, they're living in a lot of other places we don't want them to live. And because they are a struggling population, they fall through the cracks. So I listed the other mainly to cover myself, in case you know one place they live better than mine. And I'm not seeing the comments, Miss Beth, so if anybody makes any comments, please chime in. I wasn't able to get all that with all these other screens up, but and that is going to pop up, and not happy. My schedule was not happy. There we go. All right. Full of technical difficulties today. So other. So I just wanted to compassionately also throw out that these are the type of people that will live on the streets. So I'm moving on a little quicker too, because I can already feel myself falling behind. The other reason I want to throw in the other is because the research I was seeing are based on surveys, and I threw this slide up as just sort of an example. You know, they survey, where do you live? And down in here, you're going to see some statistics, but these statistics are skewed. I mean, look down here, you know, this particular graph was, I think, based on 2,900 respondents, and most of them were not the people with ID, it was somebody who was taking care of them. And I think that already skews the statistics. And I particularly put this slide up because Abilene, where I work, is considered a rural area, and we're constantly not getting a lot of resources that go to the city, and it's because everybody believes that a lot of people live in the city. And I think a lot of people with IDD do live in cities. But there's a lot of people out here with IDD too. I truly believe my bones. I just don't have the numbers and statistics. And I think the reason is because if you live in a large city, you're more likely to have services. And those are typically the people who respond to surveys like this, are the people who provide the services. So I hope I'm not losing too many people, but if you live in a rural area, I think the people are there, and I really want to fight for their rights too. Especially in the Abilene area, we're constantly getting this pressure to go to the big city. People with IDD can't always hop on a van and go 3 or 4 hours. So I don't want to forget the rural, especially because I know the rural is not where a lot of money flows to. So I'm trying to get into some acronyms here. I try to highlight a few that I was hearing a lot during my research. I'm leaving this slide up, so if you come back to it and you want to look, if you start hearing, maybe something will show up on this list. HCS, Home and Community-Based Service, is kind of a blanket for the group home part of things that I'm going to get into in here. LEDA, this is very important. I have a whole slide on this. We'll talk more about this. RSS, Residential Support Service, that's the acronym. When they say that, they're talking about a group home. Okay. Those were those homes I was talking about. Supervised living is kind of another sort of word for group home. But as you can see there, they designate whether there's live-in staff or not. Because sometimes people don't need somebody that lives in with them. They just need somebody to come in and check on them, help them with things. So there can be some important designations there. HHSCC, Host Home Companion Care. This is a very small program from what I could understand. It's not well funded, but it's a program that tries to help people that are living at home. So that large group of people that are living at home with family, there are some services for them. I was told, according to my resources, those services are even more modest than people living in group homes. So that's the way I kind of highlighted that. One more I didn't highlight there, and I just noticed it, and I don't know why I didn't, was LAR. This one's very important to you. This is a legal authorized representative or guardian. I'm not going to get too much into guardianship right now, but I do want you to be armed with the fact that if you're working with people with IDD, their rights as an individual are very important right now, especially on your consent forms and things. When in doubt, have everybody who can sign it, sign it. That would be my only advice to you. That's free advice. We're going to get a lot of free advice today from Dr. Bullock. It's free, take it for what it's worth. But LAR, I used to call guardian when I was in pediatrics. Who you have sign the consent form does matter. So know that acronym, LAR. LEDAs, I told you I'd get into LEDAs. LEDAs are local IDD, intellectual developmental and disability authorities, okay? I wanted to go over this because I think this is, we're going to get down to some more of that free advice, so I'm going to get into it more, but I want you to know what LEDAs are. Okay, so they are service coordinators for individuals with IDD. They are private businesses. There is a LEDA for every region, and the regions overlap, but all regions in the state of Texas have a LEDA. Okay, and I'm gonna get in a minute why that's important. But because they are private businesses, the LEDA in your area may not be like a LEDA in a different place. And so do understand when you talk, if you followed my advice and you talk to a LEDA, but from my research, this is where you're going to find out from this LEDA is what the state of the system is in your individual area. And I'm going to get into that. I actually have contact information and everything. So I'm going to move on a little bit from there. But I put this up as a website. I'm going to scan through a bunch of these LEDAs. This is really for my folks that are watching this later and can pause on the one that you want, jot down a number. So I'm going to go real quickly here. Okay, so here's a list of LEDAs by region. by city. And as I've been told, this contact information is fairly up to date. It's from last April, but hopefully these numbers and contacts will get you started if you're interested in this kind of care. Like I said, I'm just trying to arm you with some basic knowledge. And sorry for the boring visuals. Like I said, I just, in our great time where we can go back virtually and hit pause, hopefully that's helpful to somebody. So free advice time, warning, take this for what it's worth. This is just my free advice. I'm not out there doing this kind of care. I'm a state employee, but I would like to see these people get care. So I'm hopefully going to give you maybe some idea of what I would do if I were you. Of course, I'm not. So if I were you, I would contact the LEDAs in your area. And I hope I made that a point previously. The reason is because they're going to know what group home providers are in your area. They should know what the kind of makeup of those people living in those various group homes are. And that's very important because the people get separated out to different group homes based on their disabilities, both medical as well as behavioral. I want to encourage you to try and focus on the types of cases you're comfortable treating. As more and more of these type of people leave my system, that means more and more of them are out there in the community with more and more needs. So if you're really only comfortable treating pretty high functioning people that you can talk to, tell the lead of that. They hopefully will get you in contact with group homes that house those type of individuals. I'd love to see you all grow your practice and treat a wide range of people with IDD, but I'm going to encourage you, start with the ones that have pretty normal needs as well as pretty normal dental needs, especially if you've never done it before. Now, if you went and did an AGD and you're awesome and you want to treat everybody, jump in feet first, tell the lead of that, but be careful because you may be the only person in a 100-mile radius doing it, and you will get everything from what I've been told. At least that's what my lead did. I was like, if I had a dentist contact you, what would you say? Like, he'd be like, work here, we got you, because it's kind of desperate out here. So the LEDA can also help you with funding. The LEDA can also help you with talking to other service providers, and I would encourage you to do this if you're just jumping in. Like I said, I'm giving you a very cursory amount of knowledge here because I only have a very cursory amount of knowledge to give you. I think the best person that would be giving this talk right now would be somebody in private practice who's actually doing this already. I just couldn't find that person. I actually did ask, but I wasn't able to get anybody to do that. But there are other service providers treating IDD. The LEDA will know who those people are. I would encourage you, if you can, try and get a hold of them, because how they bill and some of those type of issues I don't have as much experience with, some of that billing is kind of the same, as well as they can give you insight into the group homes that sometimes the LEDA can't or won't. And we're going to get to group homes real quick. I know that's actually the title of it, but LEDAs. That's where I would start if I were going to kind of start branching out into this. So moving on into group homes. Like I said, the kind of purpose of this talk changed after a while. Group homes, beyond, so what should they have? They should, from what and I'm trying to keep this broad statewide because I know hopefully all of y'all are from around the state of Texas more than just here. But I've been told they should all have transportation. They're usually small homes in that 3 to 4 bedroom range. They are all private businesses, from what I've been told. Live-in staff member, I was told that many of them do. There was that special other designation that's a pretty small amount of people. You know, usually people that need money from the government to live, they need somebody on site to ask questions to. So there's often a live-in staff member. Limited funds, again, I told my LEDA contact that I would try and keep you modest. There are limited funds. The care is beneficial. It's not well funded right now. I understand that, but I think it's a chicken or the egg problem. I think dentistry needs to come together and say the funding needs to improve, but at the same time, we can't have the finger pointed at us and that, well, you're not doing it anyway. Why do you need more money? Nobody's doing it. So again, those are hard conversations, but nurses, there oftentimes will be a nurse involved. That's going to be important because that's who you're going to be talking to about your medical histories and things like that. That nurse may know them very well, they may not. But it's not going to be a normal caregiver situation a lot of times with a mom, who knows every pill, every cough that this person has had. You may end up needing to talk to a nurse about a person's current medical state, as well as the medications they're on. A lot of times the caregiver that drops them off, he doesn't know because he's not the one giving those medicines, unlike with a mom. Other obligations, just know that if they live in a group home, they have other rules they live by. They have to go to community centers. It's going to be a little more rules than working with mom and dad in a home environment. So just be aware of that, So now I said all that. I could only put these things up because the first note I have here when it comes to group home is they vary greatly. Please be careful and don't get frustrated is my point behind this. If you start working with a group home, ABC IDD Group Home Inc., and it doesn't go well, call your LEDA and ask to work with another. Please don't just abandon. I mean, I feel bad. You feel bad abandoning. I know I would, because it's not those people's fault that the home company they live with is not the best in the world. They're not the most timely paying their bills. They're not the great about bringing them. I know that's not their fault, but I promise you there's an IDD person living in another group home that maybe you can work better with, because where they live does impact your care. So I guess I'd throw that out as just because one group home was hard to work with in your area, that does not mean they all are. You might find a relationship that works better for you. Like I was talking about, they're kind of funded like a nursing home. From what I've been told, again, I'm not the expert, I wish I was, you're going to be getting Medicaid type money, and they may say, oh, they get Medicaid money, but a lot of times you're billing the actual group home company itself. So it's not a direct Medicaid. It's not necessarily you have to become a Medicaid provider, especially for the adult care type stuff. Now with the kids, they may actually have Medicaid that is the right kind of Medicaid where you need to be a Medicaid. So just be careful with that. But if you're billing the home, now they're going to limit you to the 2,000 because that's all the money they get from what I've been told. But who you're billing does matter. So, have that worked out ahead of time. And I got to move on. I feel like I could talk about that all day. The problem is I really don't think I could have talked about that. At some point, I think I would have started saying things that aren't true. So I did split this into another one. I really just wanted to highlight the program we have here, which is what we call lovingly the Abilene State Supported Living Center Desensitization Program. So a while back, the lovely Department of Justice came into the state of Texas, and they said we were not providing care, not just dental care, but all care incorrectly. And one of the buzzwords they threw out was desensitization. They used that word. I did not. But when I first started working here, it kind of had taken root a little bit as dental desensitization. And we had to call it that because that's what DOJ understood. So what is dental desensitization? It is a program that I have being run by a dental hygienist, and what its purpose is to try and help them be better dental patients. That's kind of the best way I can sum it up. Desensitization is part of it because a lot of them do need that, but a lot of it is just learning and teaching. Now, we do ours at an off-site facility. This is 7th Street Mock. It's actually next to our beauty. If you zoom in real close, you can see beauty shop there. That was a special thing that we felt like we needed here at our facility because my dental clinic is actually located in the same building with the infirmary, which is where they get their medical care, and unfortunately has a long history. When they need medical care, they need medical care. So a lot of them are scared of this building. And so we house it off site because they're not scared of that building over there. In fact, some of them enjoy the beauty shop, so they prefer to go there. That makes them easier to get there. But even though it's housed off site, we tried to make it look as similar to one of our dental operatories. And I know the equipment looks a little old, but we tried to break it down to what a dental office would be. There's a dental chair in a dental room. There's a little waiting area. There's a hallway. And that kind of stuff is important, we feel, because they need to see what the expectation is. And that's really what it is. We tried to decide, what would a good dental patient do? They would come in, they would sit, they would get their teeth cleaned, they'd get some x-rays, they'd get up, they'd leave. Of course, if it were you, they'd pay your bill, not here, but so good dental patients. So we tried to break that down into skills, and we tried to create an environment where we could teach that skills. Also in this picture, you're going to see some sensory items. We call them sensory items. With IDD care, a lot of autism, a lot of disabilities. We use sensory items. I don't have enough time to go into all that. I just wanted to highlight that this program also is a little more than I could provide, because my hygienist is so knowledgeable and works with a lot of other departments like our HAB therapies and our behavioral health people to help come up with distractors and supports and sensory items that help people. And so we've moved beyond a little bit more like using the x-ray gown as a weighted blanket. It was my point with that. So how does it work? They come in for initial assessment, working assessment. So initial assessment, we found out real quick, this is a labor intensive program. We can't do everybody, especially all at once. And everybody wanted us to, like, why can't Pam see everybody? So we found out real quick, we had to assess people real quick and dirty. Yes, we think they should be in the program. No, they shouldn't. If yes, they're on the wait list. Okay. Working assessment was after the initial assessment, which may have been some time ago. Pam can really focus on them. What do they really need? She sees them in sessions very similar to the formal program, which we'll get to. But she needs time to work with them to actually tell what they need, work with their caregivers. Formal programming is when we've identified what skills they need, and we actually just say, here's what we're working on, and we work on them, and then we discharge them. So I kind of made this like a real program, which worked out here. And then we reassess them on a frequent basis. The reason is because no behavior sticks forever. People change. Even the people we said were not candidates, sometimes they change. Everybody changes over time. And so sometimes somebody wasn't appropriate. Maybe they were sick. Now it is appropriate to bring them back in. So we do a lot of reassessments. So what gets trained? Like I just said, what makes a good dental patient? We use a lot of behavioral techniques we learn from the pediatric people. We tell, show, do. We model on the literal model there. We brush teeth. We're teaching things that are scary to people with ID, or maybe scary to them that aren't scary to us. Blood pressure and pulse ox there. Suction. Somebody who has auditory autism, you turn on a suction machine or a Cavitron, it can be very frightening. Scaler, that's actually a plastic scaler. We do try and teach them / desensitize them to hand scaling as well as ultrasonic. Ultrasonic is a little trickier because of water and swallowing issues. But my point was, we're trying to teach the full gamut. We also do x-rays for people that it's appropriate. Here are the common techniques we use. You're going to notice some of these are kind of out of the psychology world, which we had help when we were designing our program. Modeling, show it on us, show it on their caregiver, show it on the modeling. Desensitization, that's a specific, I know the program is called desensitization. That's a very specific in the psychology world. We do some of that, but we don't do it quite like they do. That's why our program here ended up in the dental office or the dental department, is because they didn't understand the dentistry enough, but we were able to understand psychology just enough. I'm not saying we do it perfect, but also what really helps them is the routine. if they come in, we call it teaching them to dance. They come in enough times, they walk down the hallway, they sit in the chair, they get greeted by a person in a mask, they get a few things done, they get out. A lot of times that translates over to my main dental office. It's like, oh, I know how to do this. Oh, I come in, I sit down, I get up. It's that same routine you and I learned at our first dental appointment in about 5.5 seconds, but it takes them sometimes months, if not years, to learn that routine. Sometimes they never get the routine, but we identify the people that can learn the routine. Also, what we really use desensitization for is supports, reinforcers, and distractors. You do this probably a lot in your own practice. You may not even know it, but hey, little Johnny, if you do really good, you can have a you can have a popsicle or a sucker at the end. You know, maybe that gets somebody to sit there. But even your adult patients, you may tell them, hey, we can get this filling done. You're doing a great job. It's a reinforcer. So we identify things they like, things that motivate them. We try to limit as much as we can bargaining with them. But, at the end of the day, if somebody can get their teeth cleaned and I can hand them a little little thing for them at the end to help motivate them to come back the next time, I think that's good for their dental health. But I got to know what to give them. It's not that the same things are not always important to the same person. We also do have to watch with the toys and what's called age appropriateness. Yes, they're adults, but some of them really love sparkly things because that's their developmental disability. That's probably not so much for you guys, but we really have had a lot of success in our program identifying things that help them through the appointment as well as after. So I'm coming near the end of my talk, I promise. Why did we do this program? Well, DOJ wanting us to do this program helped out a lot. But when I came on board, I saw the value in it, that a lot of people with IDD care fall into two groups. A lot of the older population with IDD come from the bad old days of dentistry. You needed a filling done, you needed a cleaning. And I'm talking the bad old days, 50s, 60s, but even all the way up into the 70s, 80s, and 90s. We don't do it this way now here, but I do know for a fact it happens. It probably, but I get the feeling it's not having as much, but we all know that the old technique was strap them down, hold them down, full awake, no anesthesia services. We are still dealing with the fallout of that because our aging population that aged. We can help those people. We can help teach them. Our program has helped teach people that that's not the way we do it anymore. But people with IDD, you can't just say, Johnny, that's not how we do it anymore. You got to show them. So we have shown some people. The other group of people that I've noticed coming into our facility are the younger people. They actually haven't had all that traumatic dentistry done to them. Thankfully, they have not. I think the expansion of anesthesia services, the change in our philosophies in dentistry, not so much voice control, which even I learned in middle school. But those kind of techniques are going away. But what that means is a lot of them don't know how to behave in the dental office because nobody's ever taken the time to teach them. They were sedated for every appointment. They were under general anesthesia. And what we're finding is some of them can learn how to do that. Lastly, the why is because we have a lot of services at our facility. This program is one of the ways that we're able to integrate all those services into their dental care. It really is a team effort. And at our facility, we decided that integrated care was better care, that we can't practice in silos. So this program was one of the ways that we were able to get around that. Comprehensive care for all. I just want to throw out here, yes, we've had a lot of successes with this program. We've had a lot of people that it was not successful with. The success was modest. I think it would be much better in patients with higher functionality. That's just not what my facility has particularly. We have had a lot of cases where this program was very helpful for regulatory pressures. I don't know if that's coming to the private sector. I don't want to go into any of that, but it was our answer to a lot of regulatory, why are you putting this person under general anesthesia? What else have you tried with them? That this program was our answer for that question a lot of times. And it was an important answer that we were trying other things, not just putting everybody to sleep for their dental care. So I have now come to the end of my program.
Let me ask real quick, Dr. Bullock, do
Yes.
all of the SSLCs in Texas have a desensitization program like you all do?
No, ma'am. Unfortunately, that's why I kind of had to highlight ours. So some of the facilities were not able to implement that. My particular facility, we have been extremely blessed with. My predecessor was here for 40 years. When I took over for him, we've had a long history. Some of the other facilities have had a harder time with continuity of care. They had to focus on their dental care. Some of the facilities, other departments took on this mantle. Like I said, this program at our facility was a huge blend of dentistry, psychology, psychiatry, HAB therapies, particularly occupational therapy. So at some of the facilities, this mantle was picked up, from what I've heard, by the behavioral health people, and it looks very different when they do it. Because like I said, they're coming at it from a different background. So as far as I know, we're the only facility that ended up with this exact particular program. It's very unique.
Very impressive. It's very impressive. I can see where it would be very advantageous to have your patients, go through that first. The other information about the group homes was really interesting. I learned a lot today from you, and about the LEDUS. Is that how you say it?
LEDUS, yeah.
LEDUS.
And that's what they call themselves.
Okay.
I was like, who are you? We're the LEDA. So that's why I wanted to arm you with those acronyms.
And I have a group home just down the block from us, on the same block, that have been there several years.
Yes.
And you wouldn't know it from any other of the homes on our block.
And I was told you probably, if you live in a neighborhood, you probably have one of these homes in your neighborhood. They're that ubiquitous. I mean, I'm sure that's not 100% accurate, but they're kind of all over the place from what I've known, from what I've been told.
Well, that's good. I mean, if they're trying to transition into that community, services and things, I think it's a good transition.
Yeah.
Does anyone else have any questions or comments that they would like to make? And you can also raise your hand if you want to ask verbally.
Yeah. If not, I also left my, as I do with all my presentations, hopefully it's still up there, or you can get it back. I'll put up my personal email. Please, let's continue the conversation. Or if you really took issue with something I did say, like I said, I want to continue this conversation. I think Texas dentistry is the people who are going to fight for people with IDD.
Thank you for that. And then we do, as I said in the beginning, we do have all of your presentations. This recording will be added. Dr. Bullock, I want to thank you for doing all three of these presentations for us, for the coalition, and to help spread the word to different providers, dental providers, and anyone working in oral health, especially in Texas. You really provided a lot of good information, and it was information designed for the practitioner, the private practitioner dentist, that how can I start seeing patients with ID? What do I need to do? Different things like that. And you really provided all those details for us. So I appreciate all of the time and effort that you did to present for us over the last several months.
Thank you.
Again, that LEDUS spreadsheet that he had that was showing all those different areas in Texas, that's a handout that you can download. There it is again. So it's on the website. It's also in your chat box where you can copy paste it into your browser.
Yes, ma'am. Bye-bye. Thank you very much.
Thank you. Bye-bye. And with that, I will bid you all adieu and wish you all a very nice weekend. So thank you again for joining us this afternoon.